Good afternoon and happy Valentine's Day. Thank you for joining us today for Ladies Let's Talk, Bodies, Relationships, and Health. I'm Catherine Strode, the Policy Outreach Specialist at AdvocacyDenver, formerly known as the ARC of Denver, serving people with intellectual and developmental disabilities. We have a really distinguished panel of professionals with us today to join in this discussion. The focus of our webinar today is the significant disparities in health and medical care utilization experienced by adult women with intellectual and developmental disabilities. Starting off our discussion is the chronic disease specialist with the Colorado Department of Public Health and Environment, Tara Trujillo, who will give us an overview of the chronic disease rates among women without disabilities in the state, followed by AdvocacyDenver's adult advocate and wellness educator, Mary Simp. Mary will give us an overview of chronic disease rates among women with disabilities and the barriers they face in getting care. Planned Parenthood's education program manager, Julie Labar, is with us today. Julie will review the stigma and the barriers women with disabilities face in obtaining sex education, and she'll review statistics among this population as it relates to sexual abuse. And finally, Boulder therapist Carmen will discuss the challenges all women face in developing positive body images. So today we're going to begin, again, as I said, with chronic disease specialists for the state's Department of Public Health and Environment, Tara Trujillo. And Tara, thank you for taking time out of your schedule today to be with us.
Of course, thank you. Can you hear me okay, Catherine?
I think we can hear you just fine.
Okay, terrific.
I'm going to advance the next slide.
So thank you so much for letting me come and be part of this conversation. We look forward to hearing the other speakers as well. What I will do is provide just a little bit of a background in terms of data related to women's health in Colorado, and specifically data related to the health of women with disabilities as well. So let's just talk a little bit about how many women there are in Colorado. There are 2.7 million women and girls in the state. There are about just shy of 20% of women who are 18 and older who have a disability. So we're talking just about 20% of folks. Thank you. This slide that you see here in front of you just gives a bit of a lay of the land when we're talking about disabilities within the state. This is overall numbers. There are a higher percentage of people with disabilities that we see at older ages, so you'll start to see that creep up to about 30% of folks who are in the age group of 65 and older who have a disability. There are more females than males with a disability in the state, not by a huge margin, but not one that is insignificant as well. We also start to see some disparities when we're starting to talk a little bit about race and ethnicity. For folks who are white, who have a disability, that's about 15% of folks. And we see that number rise as we move through some of the other races and ethnicities, Black, Hispanic, Asian, all the way back up to American Indian and Alaska Native, who report disabilities at the highest percentage, which is about 33.9 or almost 34%. So this slide, I wanted to show a little bit about the differences in disability for different populations. For the categories of disability, you see hearing, visual, cognitive, ambulatory, self-care, and independent living disabilities. For women specifically, we see the highest rates of folks who have a mobility disability or a cognitive disability, respectively. So this breakdown is really important because we always hear about preventing and managing chronic diseases. What's the one thing you always hear is stay healthy, right? Eat right and remain active. And those two things are a little bit more difficult when you're living with certain disabilities that, for example, restrict your mobility or restrict your access to programs that prevent or manage disease. So it's really important for us as we're looking at some of these disease states to figure out how we better make those programs more inclusive of folks who have disabilities. So let's talk a little bit about obesity first. So as you might be aware, obesity, of course, is a precursor for and often occurs in combination with other chronic diseases like cardiovascular disease, diabetes, and even cancer. When we're looking at the diabetes, or we're looking at the obesity data, we see that there really isn't much of a difference between men and women in terms of the percentage of each who are obese. They're both right around 20%. The real differences we start to see are in age. Those over 45 have a higher percentage than those who are younger who are obese. We see strong differences in obesity percentages when we get to race as well. So Hispanic and Black Coloradans are reporting higher percentages of obesity as well. We also see higher percentages for those who have lower educational attainment, those with lower incomes, and those who are Medicaid or who have military coverage, which is an interesting one as well. And I apologize that this is the only slide for which I do not yet have Colorado data, but I suspect that the national percentages hold true for the state as well. You see that obesity rates for adults with disabilities are 58% higher than for adults without disabilities. That is really significant. We're talking about obesity as a precursor to chronic disease. We're starting to see more folks with disabilities who have that precursor, and so we'll see folks with those chronic diseases with disabilities at higher rates as we move down the line as well. So let's talk a little bit about blood pressure. And I talk a lot about blood pressure because it is one of the biggest modifiable risk factors to avoid heart attacks and strokes that we know of. And heart attacks and strokes are the biggest killers of folks in the state of Colorado and across the nation. So being able to manage and control blood pressure is one of the things that we think is most important. We see for blood pressure that women are actually doing a lot better, well, maybe not a lot, they're doing better than men. We do start to see, again, those differences in the same kinds of areas. So we start to see differences for folks who are older, folks who are Black, folks who are on Medicare, report having high blood pressure at higher percentages. So I'll look at those two blue boxes at the bottom. If you would go back, Catherine. I want to call out these two sorts of things, and these are on subsequent slides as well. It's one thing to be able to talk about the number of folks who have a disability who also have a condition. The flip side of that data is when we're talking about those who are in the universe who have a condition who also have a disability. Because it's important for us to look at those things. We want to make sure that the programs that serve folks who have these different diseases are inclusive of folks who have disability, because you see that there are high rates of folks who have high blood pressure, for example, who have a disability, about almost a third, a little over a third. And that's important because we see a lot of the programs that serve folks who have these different conditions are very condition specific. So you might have a diabetes prevention program, you might have a diabetes self-management education program, you might have a home blood pressure monitoring program. And it's important for us to look at who are the folks that we are serving through some of those programs, and how do we make those programs more accessible. You also start to see high rates of folks women who have had a heart attack also report having a disability as well. That's at 60%. So that is pretty significant when we're talking about programs who serve women who have had heart attacks, strokes, or angina in the past. Next slide. So for diabetes, we note again, similar to the blood pressure slide, that women are faring a little bit better than men when it comes to diabetes. The same demographics, again, report having diabetes at higher percentages. The percentage of Hispanics with diabetes is twice as high as it is for whites, and the percentage of Blacks with diabetes is 3 times as high. So that's where we really start to see that strong disparity. We see about almost 40% of women who have diabetes have a disability. Next slide. Asthma is another key chronic disease that we wanted to make sure we touched on. For asthma, we see a definite difference between males and females, with about 10% of females reporting having asthma, and only about 7% of males. So there is one where females are experiencing higher rates of that disease. Another interesting difference for asthma is that we see gay, bisexual, and lesbian populations reporting higher rates of asthma, 13%, and only about 8% of heterosexual population reporting having asthma. So that is an interesting difference there as well. And again, about a third, in that bottom blue box there, about a third of women who said that they had asthma also reported having a disability. COPD, emphysema, and chronic bronchitis are also key conditions we wanted to make sure we touched on for this presentation. And this slide shows a little bit of a difference between females and males. Females have a bit of a higher rate. Blacks and non-Hispanic boys also have higher rates of COPD, emphysema, and chronic bronchitis. You also see those who are older, older adults population over 65 also has a higher rate too. This one is also really interesting because you see in the universe of women who have who have COPD, who have emphysema or chronic bronchitis, 60% of those women also have a disability. And I apologize if disability is spelled incorrectly on this slide. I did not catch, but you'll see that those rates still hold true. Next slide. So depression is another key chronic condition that we want to talk a little bit about. We see a higher percentage, definitely, of women reporting depression than men, by almost 10%. One of the things to keep in mind with this data is that it is survey data. It is self-reported data, so that might have a little bit of something to do with it, but still, it's not insignificant. It is almost 10% higher for women. You'll see that this number as well of folks who, in the universe of women who have a depressive disorder, 42%. So almost up to about half of women who have depression also had a disability. Next slide. So so we've been talking a little bit about the data as it relates to chunking out sections of folks who have specific disabilities, and talking about those sections of folks in terms of whether they do or do not have a disability. Let's flip this data a little bit, and this is a really good slide to be able to talk about the overall percentages of women, the differences between women who have a disability and women who do not have a disability for each of these disease states. And we see for all of them, high blood pressure, high cholesterol, which we didn't have a specific slide about, but is here as well, heart attacks, asthma, emphysema, bronchitis, arthritis, diabetes, and depression. For all of those different disease states, we see that women with disabilities have higher percentages of those conditions than women without disabilities. So I don't want to leave this data presentation on a down note. I want to tell you just a little bit about CDPHE's inclusion maps. These maps are available at the website that is listed there on the bottom of the slide. They were originally developed to map out burden geographically, so you can see that they do that by the different types of disability. And I took a screenshot of the slide that talks about ambulatory mobility difficulties. But what the interesting thing and the great thing about these resource maps is they're a great place to go where there's a lot of different resources mapped out in one area. So if you're looking for specific resources in the northeastern part of the state, it will tell you what those specific resources are. Those things might include things like the area agencies on aging. They might include things like the BOCES. They might include things like diabetes prevention programs in that part of the state. So please check out that website and those maps. They will be they have a lot of really great information that's mapped out to track. And that's it. Thank you so much.
Thank you, Tara. And this is your department's statement of its commitment and to this area. I know that you wanted the sign on this slide on. Did you want to say anything about it?
No, and thank you for putting that up there, Catherine. I just wanted to reiterate that when we're talking about health disparities, when we're talking about any specific population, just want to acknowledge that those things are not inherent in that specific population. Those things are a result of a lot of other components, life factors, geography, other environmental things that are going on. So just wanted to make sure that we acknowledge that that was the case. I know that there's another presentation that's going to touch on this as well. So thank you.
And I did want to let everyone know that Tara will be hanging around until the end of the webinar, where we will be taking your questions when we are through our slides. So again, Advocacy Denver, we serve people with intellectual and developmental disabilities, and we wanted to define that, so we were very clear about the population that we are speaking of today. So people with significant disabilities account for more than 12% of the U.S. population, and we thought it was important to understand the accepted definition of intellectual disability. It's defined as a below average cognitive ability with the following three characteristics. That first characteristic is having an IQ between 70 to 75 or below. Second characteristic, significant limitation in adaptive behaviors such as life activities that include socialization, self-care, communication. And the third characteristic is the onset of disability occurring before age 18. In addition, we wanted to give you the definition of developmental disability. Developmental disability includes people who have an intellectual disability, as well as autism, cerebral palsy, and severe seizure disorder. Under federal law, DD means a severe chronic disability of an individual that is attributed to a mental or physical impairment or both, manifested before an individual is 22 years of age, and is likely to continue indefinitely. And the presence of developmental disability results in substantial functional limitations in 3 or more major life areas. Throughout the rest of this presentation, the term intellectual and developmental disabilities is going to be referred to as IDD. Advocacy Denver's adult advocate and wellness educator, Mary Sims, will now review the chronic disease rates of women with IDD in Colorado and the barriers they face in seeking care. Mary?
Thanks, Catherine. Breast cancer is a major public health concern for all women, including women with disabilities. Women with IDD are significantly less likely to have been screened within the recommended guidelines, less likely to be current in mammograms and Pap tests. The Centers for Disease Control and Prevention have compared rates of cancer screening among adults with disabilities versus those without disability. Studies show that the prevalence of mammographies among women with disabilities was lower, 61 to 74%, compared with women without disabilities. Reported Pap test use ranged from 66% among women with different types of disabilities, compared with 81% among women without disabilities. According to a report published in 2015 by the American Journal of Public Health, adults with disabilities report skipping or delaying obtaining health care 2.5 times more than adults without disabilities. People with disabilities report higher rates of obesity, smoking, newly diagnosed cases of diabetes, and cardiovascular disease. In fact, their rates of cardiovascular disease are 3 to 4 times higher than those within the non-disabled adult community. Their rates of diabetes are 5 times higher. They are 1.5 times more likely to be victims of non-fatal violent crimes. Often there are multiple barriers that can make it difficult for individuals with disabilities to access health care. The most common barriers to healthcare for women with IDD are a lack of physical accessibility, social and attitudinal stigmas and stereotypes, and communication or a combination of all of these. When we talk about a lack of physical accessibility, this may include medical offices not providing skills that accommodate wheelchairs, curb cuts not provided on sidewalks, and mammogram equipment that requires standing. Also, transportation barriers specifically affect those who do not have access to a vehicle. Public transportation may not be available, or it may be inconvenient for traveling to healthcare facilities. Many individuals are dependent on care providers to get to their doctor's appointments, and the care providers may have conflicting schedules. This means that oftentimes just leaving the home can take a lot of time and adequate planning. Social attitudes. I would now like to touch on the social and attitudinal barriers that women with IDD face. Stereotyping. Some people assume that all persons with disabilities have unhealthy lives. Stigma, prejudice, fear, and discrimination. This goes along with stereotyping that society sees disability as something negative that needs to be cured or prevented. There are also social determinants, and these include financial barriers, a lack of education, increased vulnerability to excessive healthcare costs. Communication. This one is the most common barrier is communication. A woman with IDD may have limited verbal and language skills and be unable to express what she is feeling. She may not be able to communicate health concerns or symptoms on her own. Studies also suggest that people with IDD have poor body awareness and depressed pain responses. This limits their ability to communicate their healthcare problems to healthcare providers. Often they are dependent on their caregivers to communicate their needs. And often caregivers may not be aware or even be able to recognize symptoms or notice any changes in health. In addition to the communication barriers, there is a general lack of understanding of these individuals' needs within the healthcare settings. Medical professionals may not have the awareness of how to communicate with persons with IDD. Medical staff may use medical language or medical documentation that is not understood by a person with IDD. In addition, women with IDD may not feel comfortable sharing personal details with strangers, that is doctors.
Thank you, Mary. And I think that our next presenter, Julie Labar from Planned Parenthood, has the opportunity to expand upon and will expand upon that barrier of vulnerability that women with IDD have as it may relate to their own sexuality. Julie, thanks for being here. And if you want to continue with your slides from here, I'll be able to advance them.
Okay. Thank you so much for the invitation to be here to work with both AdvocacyDenver and everybody that is on the webinar today. I will acknowledge that if you heard that coughing, that was me, and I totally apologize. I'm getting over the flu, and so I am going to do my very best not to cough. But when you don't want to cough, what happens? You cough. So my role here today is to talk about sex education for people with disabilities and why it's important, and our role as advocates for sexual health and education for those in our lives. First, I want to introduce myself. My name is Julie Labar. I work at the Responsible Sex Education Institute, which is the education branch of Planned Parenthood of the Rocky Mountains, and I've worked there for 15 years. The Responsible Sex Education Institute provides lots of different services that many people don't know about, but we provide education throughout the community across 3 different states. I'll also give some statistics today. I want to acknowledge that statistics for people with disabilities and sexual relationships are not easily accessible. And to be honest with you, there are not that many that are actually recent statistics, but I want to share those with you in hopes that that can be a conversation that we can get started in the community. And then, why is sex education needed? So this is my main goal during this portion of the webinar is I hope to have an open and honest dialogue about sex education as it empowers individuals to continue with their self-advocacy. Sexuality is part of being a human being, and at the Responsible Sex Education Institute, we believe everyone deserves the right to understand their bodies, relationships, and what sex means to them. So we provide sex education for all ages, anywhere from middle school all the way up to elderly for all different abilities. All of our education is culturally relevant, and our education is research-based. So we use curriculum that has been researched to be effective. The topics that we can provide, and these are just some of the topics that we provide for people with disabilities, are different types of relationships and what kind of touch is okay within those relationships. Public versus private, meaning what kinds of body parts can we show in public and what body parts should we show in private, what kind of conversation should be happening in public and private, and what kind of relationship touch should only happen in private versus public. Moving from friend to sweetheart, talking about there are steps to moving into a relationship. We may see the same person at the bus stop every single day, but that does not mean that that person is our boyfriend or girlfriend. There are steps to going into relationships, and we talk about that. We talk about the body parts. We talk about every single body part. When we go to the doctor, we need to talk about the sexual body parts. Their functions and how to keep them healthy, and that's the start of that conversation. Sexual feelings, attractions, and acts. This is how our body reacts when we get sexually excited. If we don't tell people how their body reacts, it can be a very scary, very confusing thing that happens, and it can cause people to feel discomfort about sexual feelings. And then, of course, understanding and respecting consent, making sure people understand that consent is about saying yes to a behavior and that everybody has a right to say yes to what they want and what they don't want. Great. So the statistics that we were talking about. So the first statistic, among adults who are developmentally disabled, as many as 83% of females and 32% of males are victims of sexual assault. This is an incredibly high percentage. And so we need to know that, and I know that everybody who works with this community knows that it can be a vulnerable population. It's incredibly important to know that part of sex education is allowing somebody to know the language in order to get support and help. 40% of women with physical disabilities report being sexually assaulted. And then the most recent statistic is this third statistic, and it's from 2013. And the rate of sexual abuse varied greatly among victims depending on the type of disability they had. So 47.4% of people with mental health conditions reported being victims of sexual abuse, 34% of those with intellectual or developmental disabilities, IDD, and 31% of those with mobility disability. And then they actually separated autism, and that's 24.9% of those with autism reported they had experienced sexual abuse. I think that we need to take these statistics with a grain of salt and realize, number one, that there's not very many reports out there. So the very first one was from 2000, and the next one isn't until 2013. So we're lacking in these reports. Number two, are the people who are asking these questions, do they know how to ask the questions in order to get the information they need to get these reports? So it's really important to know that it's possible that some of these are actually higher than what's being reported. Okay, so I wanted to specifically focus, because we were talking about for women, care for women, so why women with disabilities are more vulnerable to abuse and victimization. So the truth is that we know that this is a vulnerable population due to needing support or needing to depend on others. But studies indicate that for females with disabilities, the chance of victimization is actually higher. So the first two, the long-term increased dependency on others for long-term care and the denial of human rights or feeling powerless, with sex education, we can reduce that sense of feeling powerless. Giving somebody some information or about the language they need to use in order to say what has happened to their body parts, what body parts have been touched, actually increases somebody feeling empowered enough to report abuse. So the fourth one, the difficulty some survivors have in being believed. This can be due to communication of victims. This can also be the system, can be the justice system or people who work with abuse survivors not having the skills or the education to working with somebody who is developmentally delayed. And then the one I really want to focus on is less education about appropriate and inappropriate sexuality. That lack of information can actually cause somebody to be more vulnerable, not understanding that their body, they have body autonomy. They're allowed to say that this is my body. You are not allowed to touch this part of my body. Understanding roles within relationships, that your doctor should be touching that part of your body when you're at a doctor's appointment, but not outside of a doctor's appointment. Understanding roles. And then that self-advocacy and boundary setting is incredibly important. The lack of access and information is incredibly large in this community, whether they missed it because of being separated in school, whether maybe the people who support them don't feel comfortable having these conversations. Lack of access to a computer, or even having access to a computer, but it has blocks on it. So not being able to get information about their bodies, about relationships, and about sex can put them at a higher risk. Okay. So why is sex education needed? Well, this is my realm, so I feel like it's needed. But other than that, sexual self-advocacy is harder than self-advocacy. In general, society has a hard time talking about sex and sexuality. Oftentimes people feel uncomfortable. How many of us know adult women who aren't willing to talk to their doctor about their sex lives or their sexual partners? This isn't about somebody who has a learning disability. This is about the topic. And so if we can develop those skills in order to have those conversations, we're empowering people to be able to have safer conversations. So those skills, understanding their own bodies, understanding what sex is, and what can happen if somebody has sex, both the positive and negative consequences, and understanding their right as a human being to be able to decide whether or not they want to be sexually active. It also needs a different support staff. So maybe their primary doctor doesn't provide annual exams. Maybe their support staff in their transition programs, their day programs, where they live, have never had the training or skills to have these conversations. Also, sex education is needed because sexuality is a normal part of development. It's really important to know that studies show that oftentimes people who care for or have family members with IDD put people in two categories. Either they're not sexual at all, or they're overly sexual. So somebody with IDD doesn't have a sexual feeling at all, or they're inappropriate. Maybe that person who doesn't understand that they shouldn't put their hands down their pants in the middle of a grocery store. But the truth is, sexuality is part of a continuum, and every human being is on that continuum, and it's really important to empower people to understand what that means for them. So the last thing is prevention, and not the last thing, second to last, prevention. We need to actually teach boundaries. We need to teach consent, that people have to say yes to being touched, their body being touched. Specifically people whose body have to be touched because they have support staff that help them get dressed, help them get in the shower. That consent is important, that every single time their body is being touched, they get to say, yes, I want my body touched right now. And that body autonomy is incredibly important. The last reason is everyone has questions and everyone deserves answers. When you feel like you have a question and you don't have someone to go and ask, you may feel like that question isn't relevant, or not everybody has those kinds of questions. That's what we want everybody to understand, is that everybody has questions about their body. Everybody has questions about relationships, and you deserve answers when it has to do with sex and sexuality. Oh, that's it. I was really getting into it.
Well, you'll have more opportunity. Again, I want to remind our attendees that at the end of the presentation of the formal information, we'll be taking questions. And you'll be able to, on the screen on your right, enter your question, and we'll be able to address them to the individual you would like them addressed to. So I want to thank Julie, and I want to introduce Carmen. Carmen Cool. She's a psychotherapist from Boulder, and she's now going to be discussing women and their own body images and women's wellness, how that connects to it. So Carmen, thank you for being here. And if you want to tell me when to advance your slides, I'll be controlling it from this end. So thanks, Carmen, for being with us today.
Thanks so much for having me. Can you hear me okay?
Yes, we can. We hear you.
Perfect. I'm always happy when the technology actually pulls through and works. So thank you all for having me here today. I am a therapist here in Boulder, and I work primarily with helping people exit diet culture. I work with intuitive and connected eating and pleasurable movement and body-centered practices, and really help my clients can move away from all the fixing that we're taught to do regarding our bodies. A couple things from the outset that I think it's important to know is that I really believe that our bodies are trustworthy, and that it is impossible to tell somebody's health based on the size of their body. Okay, next slide. Okay. Catherine, can you go to the next slide?
I am working on that. Just a second, Carmen. Just when you said our technology is perfect. Just hang in there for a minute.
Yay, there you go. Okay. So these statistics always make me really sad when I see them. Just when I think about the number of women, adult women and college-age women that are totally unhappy with the size and shape of their body, and actually even 5-year-olds now. I have clients who have 5-year-old daughters who are coming home from school saying that they want to lose weight, they want to be smaller, they want to go on a diet. And that's just heartbreaking to me, that we are teaching our young people, or they're kind of inheriting this message that our bodies are something that should always be less. And for young girls, it's not an idea they grow out of. I actually think it's one that they grow into. And so when women and girls experience poor body image, they often turn to dieting as the solution. Next slide. Yeah, so I think that most of us don't live in a culture that raises us to be very fluid and fluent in the language of our bodies, that we've been taught from the very beginning to accept diet culture uncritically before we were able really to give permission or to consent, that was what we wanted to believe. So I don't think this is any surprise that in this current dominant culture, thinness is what we consider attractive, and it also has come to symbolize success, self-control, and higher socioeconomic status. And that way, this current system privileges certain bodies and then sets up others to be discriminated against, and to have prejudice and stigma attached to them. I love this statistic because it's so infuriating to me about the weight loss industry. The last stat I saw was actually over $60 billion per year in revenue, and we know that dieting doesn't work in the long term. And so for me, what this means is that the weight loss industry is the only industry that works because it doesn't work. right? And when I think about how much money that is that we pour into that industry every year and what we could really use that towards, the social problems that we could solve, I think that's really phenomenal. And I want to talk for just 1 second about the link between body image and mental health. In February of 27, the American Psychological Association released a report examining psychological theory and research, and it connected the dots between girls' psychological health, their behaviors, and media influence. And the outcome is what the field of eating disorders treatment is trying to capture, which is that when all of these influences make people feel bad about themselves, it definitely has both physical and mental health consequences. And so here's a question. What is the shared risk factor of both eating disorders and obesity? If we think of those as being on two ends of a continuum, the shared risk factor actually for both of those is dieting. That's why I'm landing on that one so hard today. Okay, next slide, please. So talking for a minute about diet culture, this is what I mean when I talk about diet culture. It begins when we're very young. Again, we're indoctrinated into this without our consent. It's calorie counting, often resulting in binging and then shame and then restriction, and that cycle continues. It's when weight loss is always glamorized. I've had clients who have been very, very sick with the flu or cancer, and if people haven't seen them for a while, the first thing they say is, "You look great, what are you doing? You're so lucky," without ever knowing what reasons is. And that's the way we just glamorize this idea that weight loss is always something that we should be striving for and that it's always a good thing. And then when we believe that our body size also is either good or bad, depending on where it falls on the spectrum, and that a low weight that is often considered normal is an ongoing and expected goal that we should all be striving for. Next slide. It's also treating our body like a machine, right? Calories in, calories out. That it's a machine that we can manipulate. We skip meals, avoiding certain types of foods, try to go for long periods of time without food. And then this is the biggest one I see so much of the time, is just this total preoccupation with food, weight, and eating. That some of the clients I work with report 80–90% of their time or their focus or their thoughts is really channeled here into this preoccupation with food. Okay, next slide. I think this is important. These are some of the factors that impact disordered eating in our culture. Kind of goes to social determinants of health and intersectionality a little bit. Weight bias and stigma is one I'm going to talk about here for a minute. Dieting starts with a desire to change the size and shape of our body, and that's because of our own discomfort living in our body as it is. And it can also be because we've been told to lose weight, or because of the cultural emphasis on thinness, that we start to feel like our body needs to be altered. And then we make a plan, right? Oh, I'm going to go on a diet, I'm going to run every day, and then life happens and we fall off the plan, and then we feel guilty, and then we have backlash eating, and then we feel bad about ourselves, and then the cycle starts all over again. Okay, next slide. The next slide is going to focus a little bit on what we believe about thinness and fatness, which really talks about weight stigma, right? This idea that when I'm thin, life will be perfect. If I could just lose weight, everything in my life would be better, right? I would be happier, I would be healthier, the angels would start singing. We believe that the good things come to us if we could just achieve a certain body size. And consequently, fatness, right? If I could just lose weight, all of these things wouldn't have happened to me. It really kind of speaks to the way that we blame our bodies for the meanness of other people. And I really believe that until that changes, until weight stigma changes, eating disorders and body image concerns aren't going to go away anytime soon. Okay, next slide. And the next sets of slides are really going to look at an alternative for a weight-based approach to health, and really instead shifting that to a health-based approach. So really this idea that we all come in different shapes and sizes. If everyone on the planet ate the same way and moved the same way, we would still come in a variety of body shapes, and that's just called diversity. That it's a good thing and something that we should celebrate. And the next slide is really talking about what can we do to improve our health independent of our weight. Like, weight is not a behavior. There are things that we can do, though, that can definitely improve our well-being that may or may not result in weight loss, but can absolutely result in enhanced health. And the other thing that the principle of health at every size talks about is there are other things besides weight that impact how healthy we are, right? That sometimes we just need to widen the lens a little bit and look at the whole of our lives. Okay, next slide. Respectful care. This is really calling on healthcare providers to acknowledge our weight bias and our weight stigma in our work. And it's calling on all of us to look at weight bias as another form of oppression, as dangerous as all the other forms of oppression, that we really have a responsibility to kind of root this out in ourselves and treat all of our patients, all of our clients with respect and dignity, no matter where they fall on the weight spectrum. Next slide. We are almost done with these. So this is really looking at how we eat, and this is moving towards a way where we eat for our well-being rather than eat to produce a certain body size. So we can focus on gentle nutrition, we can focus on nutrients, but we also don't forget pleasure and satisfaction, right? Sometimes I'll ask people, if you knew that you could eat anything and it was guaranteed not to impact your weight or your health or your reputation, what would it be? So many of the times we don't allow ourselves the things that really give us pleasure. And this is also talking about the difference between fullness and satisfaction, and that we really want to put our attention towards both. And that despite what we might think, our body has all the wisdom we need about what to eat, when to eat, how much to eat, and that it tells us what it wants with respect to food, and that we can learn how to honor that. Okay. Next slide. And this is also talking about movement. I use movement as a word rather than exercise, just because I think it's more sustainable, and exercise tends to bring up images of punishing times on a treadmill or things that people don't really enjoy. And if people are engaging in things they don't enjoy, they're not going to be sustainable. So I like to tell people to exercise and eat to liberate our life force, not to try to change our body. Our bodies are designed to move, and it's pleasurable to move, and we can help people find ways to do that that are independent of weight. And last slide. This is one of my favorite quotes. It's really about our body is our most trusted ally and our lifelong partner, and the reason we get to be on the planet. So we really need to work on taking the best possible care of it that we can, let it be how it is, whatever that means for us today, right? Self-care changes from day to day, and then focus on what it is we're really here in this lifetime to do. So those are my slides for today. Thank you so much, and I really appreciate being here.
Wow, Carmen, thank you so much for that presentation. I'm sure there are many of us in the audience that can really identify with that. I'd like to open this up for any questions right now, and I have one to start off for you, Carmen, before we get into our attendees. And to ask a question, just type it into the chat box in your GoToMeeting controls. So, Carmen, you talked about weight stigma, especially with, I think you were referring to it somewhat with medical providers. Can you elaborate on that a little bit?
Yeah, I think what I mean is the way that we are all taught to view fatness or higher body weights as a problem, right? And that they're automatically unhealthy. And I think that bias stops us from treating people as whole people and looking at the whole picture of what might be going on. So in other words, there are stories that I've heard where a larger person or a higher weight person goes in for pain, and the cause of the pain gets ignored because the provider is only talking to them about losing weight, where it could be they have cancer or things that don't get diagnosed. And I believe that it's the stigma that stops that from happening. Or consequently, or another example is if somebody goes in for a strep throat, or they have a cold, and they're given a weight loss lecture. And not that we can't talk about these things, but I think I would like to see people treat conditions the same way they would as if a thinner body showed up with strep throat, right? And treat the actual condition rather than always going to a weight loss lecture. Does that make sense?
Yes, it does. And I see a question from James. James, do I have your name correctly here? Perhaps not. So another question. Oh, all right, here is a question. Are there any resources? Can I see that question again, Jeff? That appeared. It appeared and then it went away. It's a question about resources. If everybody just hangs on for a second. So, are there any resources that provide sexual education for women with IDD? I think, Julie, that's probably for you.
There are actually quite a few resources. So there, there are not that many curriculum, but there are 3 specific curriculum. One, sex education for adults with developmental disabilities, and that's through Planned Parenthood Northern New England. There is the Flash curriculum from Kings County, Washington. I will say that that curriculum is for middle school and high school, and it's a little dated. There are some words in there that are dated. And there's Positive Prevention Plus curriculum from California, and it's actually a curriculum that was written by Red Cross and people from the California Public School District. So those are specific curriculums. I also have a whole list of books and websites, which I could give to AdvocacyDenver, and they may be able to attach to this webinar.
That would be awesome.
Great.
Have another question for Tara, actually. Tara, I know that there is a health equity department within the state of Colorado, and I'm wondering if women with IDD, specifically women with IDD, is that population considered a health disparity group?
Good question, Catherine. I would say so. I don't know. The Office of Health Equity is in a different office than the Pension Services Division. That would be a great question to ask them in terms of what activities they might have that are related specifically to that population. But looking at the data, I would say yes, that is a population that would be considered a priority population.
Well, we're just about out of time. We had slated the webinar for about an hour, and I wanted to really thank our panel of presenters, Tara Trujillo, Julie Labar, and Carmen Kuhl, and our own Mary Sims, for taking the time today to inform us of this really important topic with women and their wellness that we've hosted today. I wanted to let you know that a recording of this webinar will be available on our website at www.advocacydenver.org. Mary Sims, again, is our health and wellness educator. You can contact her at the email and the phone number that you see on your screen right now. And I would also be happy to answer any of your questions regarding resources or information. So thank you for joining us today, and have a great Valentine's Day.